Hello, everyone, and welcome to our JEDI series for our Rising MS4s. I will be covering shortness of breath. My name is Dr. Alyssa Eily. I'm currently a PGY3 in emergency medicine at Mount Sinai Medical Center on Miami Beach and an RSA representative for JEDI. So a little bit about me and why I love emergency medicine. So emergency medicine is the only specialty where we get to do it all. Undifferentiated patients are a unique challenge, and we're one of the few specialties who get to see and treat undifferentiated patients. We're masters of resuscitation, and the sickest patients we see first. Plus, our lifestyle is pretty great. As you can see here, it's my wonderful fiance and our 2 dogs. We get to spend a lot of time exploring Miami, going to the beach, and taking the dogs with us. And emergency medicine gives you a good work-life balance. So today's objectives. At the end of the session, you should be able to develop at least 3 differential diagnoses for any patient presenting with shortness of breath, apply diagnostic testing for patients presenting with shortness of breath, and recognize emergent causes of shortness of breath. At the very end of this lecture, we'll also discuss indications for escalating airways, but that's not the focus of this lecture. For this lecture, I really want you to have a good grasp of sort of the meat and potatoes of shortness of breath. It's a very common chief complaint, and I want you to be comfortable presenting these patients when you step into the emergency room on your elective rotations. So shortness of breath accounts for about 3.5 million ED visits per year, and it's a very broad pathophysiology. We like to think of shortness of breath as exclusively pulmonary, but any of our organ systems can result in shortness of breath. So when you see the chief complaint of shortness of breath on the board, it should trigger you to think of multiple things, not just what could be going on with the lungs here, which is part of the reason it's my favorite chief complaint, because anything can be going wrong when a patient presents with shortness of breath. So first and foremost, ABCs. And this applies to any patient with any chief complaint, but especially with shortness of breath. Airway, breathing, circulation, those things come first. Our job in the emergency department is to be masters of resuscitation and identify patients who require resuscitation. So when assessing a patient, especially on your audition rotations, if you walk in and the patient looks sick, which sick versus not sick is a very important skill to develop, then you step out, you grab your senior, grab your attending, and let them know that you're concerned that this patient may need escalating levels of care, but always airway, breathing, circulation. Does this patient need supplemental oxygen? Does this patient need BiPAP? Does this patient need fluids, their volume down? So these are all things that we need to think about when we're approaching a patient. So this chart here is how I organize a differential diagnosis when it comes to shortness of breath. The goal of this slide is not to look at these and memorize every single differential. And trust me, this is far from every differential that we could have for shortness of breath, but it's to demonstrate just how varied the cause of shortness of breath can be. Is it a PE? Is it actually Guillain-Barré? Is it epiglottitis? Or does the person have a bowel perforation and pneumoperitoneum that's causing them to have a horrible lactic acidosis, and that's why they're tachypnic and short of breath? So remembering that when we approach a patient, when we're developing our differential, be systematic about it. So I tend to organize my differentials by organ systems. Everyone does their differential a little bit differently, but I encourage you to find a system that works for you and to go down your list and sort of move your differential around as you get more information back about the patient, as labs come back. And that's what will help you really stand out as a 4th-year medical student who's auditioning. So let's start with a case presentation. Here we have a 67-year-old female complaining of shortness of breath with pleuritic chest pain for 3 days. She has a past medical history of COPD, CAD, and has metastatic renal cell carcinoma. On physical exam, you note she's tachycardic and tachypnic, and there's also erythema and swelling to the left lower extremity. So I want you to take a minute and think about your differentials and how you would approach this patient. So what we're going for here is a pulmonary embolism. So there are about 60 to 70 cases per 100,000 people per year And it's a very often misdiagnosis. About 400,000 pulmonary embolisms are missed every year. Not to say that every PE that's missed is a clinically significant PE, but still a significant number of PEs that are missed. Black patients have a higher incidence of pulmonary embolus and mortality. They also have a higher severity of their pulmonary embolisms. When pregnant, patients are at 5 times increased risk of developing a PE. Now, in med school, we're often taught chest pain, shortness of breath, and tachycardia. That's how every patient with a PE is going to present. However, less than 20% of patients with a PE will present with this triad of symptoms. So it's important to have a high index of suspicion. So let's talk about pertinent history and pertinent physical exam findings. So pertinent history, recent travel, malignancy, and hormone use. Now, this includes estrogens as well as testosterone supplementation, because testosterone supplementation can cause a hyperviscosity syndrome. Physical exam findings can be nondescript, but tachycardia, tachypnea, hypoxia, and lower extremity swelling. And it's important to note that we most commonly think of DVTs in the lower extremities, but patients with malignancies, patients with recent instrumentation can develop DVTs in the upper extremities as well, which portends a poor prognosis. Now, when we're talking about diagnostic testing for pulmonary embolism, we have a system in place that allows us to avoid unnecessary imaging studies in patients. The one that's used most commonly is probably the PERC rule. So if we say a patient is PERC negative, that means that no further testing is indicated for evaluation of a PE. There are some criteria that they have to meet, and they must meet all of these criteria. They have to be less than 50 years old. They cannot be tachycardic. They cannot be hypoxic. They can't have a prior history of DVT or PE. They can't have any recent trauma or surgery, no episodes of hemoptysis, no exogenous estrogen use, and no unilateral leg swelling. So if you can say to each of these, the patient does not have it, then you can forego any diagnostic testing. It's really important to remember to apply this to patients who you were considering pulmonary embolism as a diagnosis. So not every patient who comes in with chest pain is someone who we want to be ruling out a PE for. So we shouldn't go around just applying this rule to everyone. It's really important that you consider your pre-test probability. So if your pre-test probability is less than or equal to 15%, and all of these criteria are negative, you can forego any imaging. Another thing that we use is the Wells score. So if a patient is not PERC negative, meaning one of these boxes on the left was checked yes, you can move to the Wells score. And this scoring is a little bit more involved. But the important thing to note here is if their score is less than 4, you can get a D dimer. If their score is greater than 4, then you go straight to CTA. And you'll see in the department, every attending applies this a little bit differently. Some people will say, irrespective of the Wells score, if they have a high clinical suspicion, they're going to go straight to CTA and forego the D dimer. When we're looking at the Wells score, we see that it does include things like tachycardia, surgery or immobilization, history of DVT, PE, hemoptysis, all of which are included in the PERC rule. But it also includes things like malignancy in the past 6 months, and most importantly, clinical signs and symptoms of DVT, meaning that DVT or PE is your most likely diagnosis. Now, after you have determined that someone has a pulmonary embolism, what do we do next? What are our next steps? So ABCs, once again, supplemental oxygen if they need it, intubation if they need it. Ultimately, you can begin anticoagulation. There's heparin, there's Coumadin, there are DOACs like Eliquis, Xarelto. It's very much dependent on your institution and the patient's hemodynamic status, which one you start. Patients may also be candidate for thrombectomy, meaning intervention with either interventional radiology or cardiovascular surgery. Or if they are hemodynamically unstable with right heart strain, then they may be candidates for TPA. Next, let's talk about COPD. So COPD has a 50% mortality at 10 years, and it's underdiagnosed in men and in people of color. When we approach patients who are concerned with COPD, we need to think about pertinent history, including smoking and environmental exposures. On physical exam, you may hear wheezing or rhonchi or even decreased breath sounds. It's important to remember that COPD is a clinical diagnosis. So yes, there's outpatient testing that is done with pulmonologists to confirm, but in the emergency department, a COPD exacerbation is very much a clinical diagnosis. So if a patient comes in who has a history of COPD, who presents with wheezing, hypoxia, tachypnea, high consideration for a COPD exacerbation. Now, a lot of patients with COPD have other comorbidities that may portend other diagnoses such as a CHF exacerbation. But for all intents and purposes, this is a clinical diagnosis. You're going to obtain a chest x-ray in these patients. And really what we're looking for here are two things. Do they have a pneumothorax, or do they have a lobar infiltrate? COPDers are typically colonized with bacteria. So we want to cover them for H-flu, strep pneumo, varicella, and Pseudomonas. The reason we treat COPDers with antibiotics is not necessarily because we think that they have a lobar infiltrate or a pneumonia, but because they are colonized and they tend to do better when treated early with IV antibiotics or oral antibiotics during an exacerbation. We'll obtain an EKG. So any patient with shortness of breath should get an EKG, irrespective of age or comorbidities. And then also COPDers, you can get an ABG. So what we're looking at here is two things. If they're presenting hypoxic, we know they're hypoxic, but more importantly, we want to see where their CO2 is and what their pH is. And looking here, we see there are two different types of COPD. So you have the chronic bronchitis or emphysematous. The reality is that most people lie on a spectrum of disease, and typically people don't fit into one category or the other. But traditionally, your emphysematous patients will present as what we call the pink puffers, meaning they're thin, they're typically very barrel-chested, whereas those with chronic bronchitis tend to have a higher BMI and more comorbidities. But there is, once again, a lot of overlap. So how do we treat this? First and foremost, supplemental oxygen. So we want to titrate to an O2 sat of at least 92%. We are not aiming for an O2 sat of 100% here. Remember, most COPDers, especially those who have progressive disease, are typically hypoxic on room air, 92%. So we don't want to over titrate them and overcorrect. Also consider that by taking care of, or by titrating them to an O2 sat of 100%, we may actually decrease their respiratory drive and increase their CO2 retention. Although it should be noted that a level of hypercarbia is tolerated in COPDers. They're baseline hypercarbic, and we want to make sure that we are oxygenating them appropriately, even if that means tolerating more hypercarbia. So one of the mainstays of COPD treatment now is BiPAP. BiPAP saves a lot of COPDers from intubation. So BiPAP, bronchodilators, typically we do duonebs. So you're getting ipratropium and albuterol, meaning you're getting bronchodilation and decreased mucus. We tend to do steroids, although it should be noted that COPD is not nearly as much of a steroid responsive disease as asthma is, but we do give steroids, and we cover with antibiotics. So common antibiotics we use Augmentin, Levaquin, and moxifloxacin, and Cipro or Levaquin for Pseudomonas coverage. You'll notice that everyone does things a little bit differently. It very much depends on the biogram and the resistance levels in your hospital. You can do magnesium. I like to say that magnesium, the only thing it doesn't treat is hypermagnesemia. So you can do magnesium in patients who are decompensating. Ultimately, if patients are tired, if they become obtunded, if their PCO2 levels are exceeding, I would say somewhere between 80 and 90, typically those patients need to be intubated. It's not something that we do lightly, given that management of COPDers on the vent can be difficult, as they're at risk for pneumothorax. But when patients are tiring out or when they have an altered mental status, you need to progress to endotracheal intubation. Let's go into our next case presentation. A 22-year-old male presents complaining of shortness of breath for one day that began as he was walking upstairs. He's otherwise healthy and active, runs 6 to 8 miles a day, denies any recent trauma. Physical exam reveals a tall, thin male with tachypnea and mild conversational dyspnea. You notice decreased breath sounds on the left. So I want you to stop and take a moment and think about how important physical exam is on every single patient. Now, you don't have to get down into the nitty-gritty of knowing, oh, is this an upper airway sound? But you should notice things like decreased breath sounds or abnormal breath sounds. So here, you have an otherwise healthy, active 22-year-old that has decreased breath sounds on the left. So what we're going for here is pneumothorax. So spontaneous pneumothoraces are more common in young males, about 5 to 1 rate of men to women. And they typically occur in tall, thin, active, otherwise healthy individuals. Now, a primary spontaneous pneumothorax is considerably different than a secondary pneumothorax, which is often from blebs in COPDers, and those blebs rupture, trauma, or malignancy. We can also get pneumothoraces that happen after interventions, but those are usually fairly small and residual. Pertinent history for anyone where you're considering a pneumothorax. Do they have recent trauma, a recent thoracic intervention? And do they have a history of asthma or COPD? Other physical exam findings, do they have decreased breath sounds? Do they have tracheal deviation? So the other thing to remember is that on the boards, Marfan syndrome is associated with high rates of spontaneous pneumothoraces, although we don't see a ton of Marfan syndrome in the ED, something to consider. So how do we determine if someone has a pneumothorax? So the diagnosis is clinical, much like a COPD exacerbation. If you think that someone has a pneumothorax, that is all you need. So always remember, your diagnosis is clinical. You are going to get a chest x-ray. Remember that ultrasound is actually much more sensitive than chest x-ray for detection of a pneumothorax. You can get a CT chest, with which most patients who have a first-time pneumothorax will get a CT chest, typically after they're stabilized. But you always have a point of care ultrasound that you can throw on and look for lung sliding. And remember, look in multiple fields. And remember that the position of the patient is going to change where the pneumothorax presents. How do we treat it? So we place the patients on oxygen. Now, if a patient is hemodynamically unstable, meaning that they are hypoxic, they have tracheal deviation, they are hypotensive, then that is an indication for needle decompression. With needle decompression, you're going to find the second intercostal space in the mid-clavicular line and use a 14 or 16 gauge angiocath and go straight down until you get that nice rush of air. Remember that this is a temporizing measure until you have definitive management, which will be a chest tube. Now, more and more for atraumatic pneumothoraces and for smaller pneumothoraces, we're doing pigtail placements over chest tube placements, which is great for patients. It tends to be a much more comfortable procedure with a lot less bleeding and morbidity. So for pigtail placement, we're going to go in the same spot that we would go for our chest tube placement. So generally, anterior axillary line at the 4th or 5th intercostal space. You're always going to go above the rib to avoid hitting the vein, artery, and nerve that run right inferior to it. For pneumothoraces that are less than 15% of total lung volume, patients can actually be observed as long as they are hemodynamically stable. There is a zone of safety. So anteriorly, it'll be the lats, and then laterally, it'll be your pecs. And inferiorly, it'll be that 4th or 5th intercostal space. So as long as you're going in this zone of safety right here, very low chance of you hitting other organs. You'll notice if you go lower down in the rib spaces, you have a higher risk of going below the diaphragm and hitting the liver, hitting the spleen. Now let's talk about ACS. A lot of ACS presents as shortness of breath. And remember that ACS is the leading cause of death and disability in developed nations. Female presenting patients have longer delays to care. And this is very, very, very important because most studies on ACS were retrospective studies, and the patients involved were cis white men. So a lot of the data that we have doesn't reflect a large subset of our population. So those symptoms that are considered atypical ACS symptoms, epigastric pain, nausea, shortness of breath, may not be as atypical as we think. There are three categories. There's unstable angina. You can have NSTEMIs or STEMIs. Let's talk about pertinent history. Previous ACS is the single most important risk factor here when we're obtaining a history. Hypertension, diabetes, smoking, those are actually very poor predictors of active ACS upon arrival to the ED. Physical exam findings can be completely varied depending on the ACS itself. Some patients arrive tachycardic, some patients arrive bradycardic. Patients can be diaphoretic, they can be vomiting. All of these things are varied. And this is why we have to have a very high clinical suspicion for ACS. Let's look at STEMI criteria because this is incredibly important. So in leads V2 or V3, for men less than 40 years old, you need at least 2.5 millimeters of elevation. In men older than 40, you need 2 millimeters. And in women of all ages in V2 or V3, you need 1.5 millimeters of elevation. In all other leads across all ages and genders, you need 1 millimeter of elevation. Now, there are lots of dysrhythmias or EKG patterns that can be STEMI equivalents, but what I want us to focus on here is the true STEMIs. And I want to encourage you that while you're on your audition rotations, make sure you look at the EKG for every patient that gets an EKG. It's the only way you're going to get better. The more EKGs you see, the more comfortable you'll be reading them and interpreting them. And at the end of the day, as an emergency medicine attending, one day someone's going to be handing you the EKG and needing you to sign off STEMI or no STEMI. So the sooner you start reviewing them, the sooner you'll get comfortable with that. All right, let's talk diagnostic testing. So EKG, EKG, EKG. Patients who present with chest pain have to have an EKG within 10 minutes of arrival, and that's a CMS policy. But let's consider patients who are presenting with shortness of breath to be in that same boat. We want an EKG right quick and in a hurry. We're also going to obtain troponins, a chest x-ray. You can do a bedside cardiac ultrasound. Sometimes they get an endotracheal ultrasound or esophageal echo. And you can do CTCAs. So those are CT angios of the coronary arteries. A couple things to note here. Our troponin, we're always going to get serial troponins. With patients who are presenting with chest pain that began within the past 4 hours, we need serial troponins and to see where those troponins are going. Some places use high sensitivity troponins, some places don't. So you always have to look at the cutoffs for the hospital that you're in. But a single troponin is not sufficient, just like a single EKG is not sufficient. So EKGs in and of themselves have very poor sensitivity for ACS. So serial EKGs increase your sensitivity to about 90%. Remember that the specificity still isn't great unless it's a STEMI. But serial EKGs, especially for patients who have ugly EKGs when they get there, or who have active chest pain or continued shortness of breath. When we get a chest x-ray, what we're looking for here are actually other causes of shortness of breath or chest pain. It's not necessarily saying that the chest x-ray itself is going to show us ACS, but it may show us a pneumothorax that we missed. It may show us a lobar infiltrate, other things that are on our differential and help us reorganize our differential. Treatment. So aspirin is the single most important thing you can do. And I know Mona Bash is harped on a lot in med school, but let's sort of throw that out the window because we really don't use it that much anymore. We try not to give morphine. Patients who get morphine for ACS actually have a worse prognosis. So aspirin, single most important thing that you can do. Aspirin decreases mortality by about 30% in ACS. Now, Anticoagulation is always a bit of a debate back and forth, depending on your institution. In the acute setting, anticoagulation, whether or not it's low molecular weight heparin, whether or not it's Lovenox, decreases mortality by about 50%, but only within the first 3 to 5 days. Beyond that, long-term use of anticoagulation isn't really indicated. We give nitroglycerin. Things to note about nitroglycerin. For those who are having an inferior wall MI, nitroglycerin is contraindicated. You're decreasing your preload when you give nitroglycerin, and inferior wall MIs are very much preload dependent. So you always want an EKG before you're giving nitroglycerin. Now, plus or minus beta blockers, depending on how the patient's presenting and depending on your discussion with cardiology. These patients may go for an intervention with interventional cardiology, depending on their EKG, depending on their hemodynamic status, and depending on the laboratory values. If a patient is having a STEMI and there is no access to interventional cardiology for PCI within 120 minutes, then they're a candidate for thrombolytics. Very, very, very important. Limit your use of oxygen unless their O2 sat is less than 92%. Hyperoxia causes free radicals and actually has a negative impact on morbidity and mortality. Let's also talk about congestive heart failure. So congestive heart failure is becoming more and more and more common. So there are an additional 500,000 cases per year. And the mortality rate is 50% within 5 years of diagnosis. We're also seeing CHF in younger patients with poorly controlled comorbidities such as hypertension and diabetes, and those with substance use disorders, those with alcohol-induced cardiomyopathies, who are otherwise young and relatively healthy. Most pertinent history when evaluating for a CHF exacerbation is, do they have a previous history of heart failure? Do they have a history of hypertension, diabetes? Are they smokers? Do they have heavy substance use? Physical exam findings. Now, typically we think of rails, but you can also have a cardiac wheeze. So remember, not all that wheezes is asthma. And in patients who are 75 and coming in wheezing for the first time in their life, very low likelihood that they have new onset asthma. So consider CHF. You may see JVD, plus or minus pedal edema, depending on the side of heart failure. Remember that the most common cause of right heart failure is left heart failure. And until you develop right heart failure, you very rarely get pedal edema. You may also have hepatosplenomegaly, which is a little bit easier to feel for in children. Adults, especially those who are obese, it may be more difficult to feel for, but you can definitely have hepatosplenomegaly secondary to all that congestion. So how do we diagnose CHF exacerbation? So you're always going to get an EKG and a troponin, a chest x-ray. So remember that chest x-rays are not sensitive or specific for CHF exacerbations. You may see some congestion on the chest x-ray. You may see some pleural effusions, but ultrasound is much more sensitive for a CHF exacerbation. And what you're looking for here are B lines. And those, you have to have more than three in a field, and they have to go greater than 16 centimeters deep. And these are very, very sensitive for CHF exacerbations. And often it's quicker to get an ultrasound than it is to get a chest x-ray. So in a patient where you're concerned for a CHF exacerbation, this is a quick and easy way to assess. You can do a POCUS cardiac ultrasound, look for regional wall motion abnormalities, pericardial effusions, and then you can also get a proBNP. Something to remember about proBNPs is that they have a lot of different factors that contribute. Age, end-stage renal disease, all of these come into play. So a proBNP of less than 300 is most likely not CHF. However, an elevated proBNP can be caused by other things. In your patients who are dialysis dependent, their proBNP at baseline may be 4,000, and they may not be having an active CHF exacerbation. So remember to take that lab value in context. And how do we treat it? So supplemental oxygen, first and foremost, for our patients who are hypoxic, for our patients who are tachypnic. We can give nitroglycerin. So at low doses, nitroglycerin causes venodilation, and at high doses, you get veno and arterial dilation. We also want to diurese them, but remember that we don't want to diurese anyone before we have their electrolytes. Loop diuretics can cause hypokalemia. Nitroglycerin is relatively safe, and a lot of CHF exacerbations present hypertensive, so sort of a 2-for-1. BiPAP is wonderful and can save many CHF patients from intubation. And then plus or minus ionotropes like dopamine, dobutamine. And then let's go into our last case presentation. A 42-year-old male with past medical history of sarcoidosis presents complaining of 2 days of shortness of breath. He endorses fatigue, polydipsia, and polyuria. On physical exam, he's noted to be tachycardic and tachypnic with dry mucous membranes, but saturating 100% or 99% on room air. So let's talk about this. This is a classic example of everything that is shortness of breath, not necessarily being pulmonary or cardiac. So here we have a young man with polydipsia and polyuria and dry mucous membranes. And he has a history of another autoimmune disease. So we should be thinking about diabetes. The first thing we want on this man is absolutely a finger stick. So this man is most likely presenting with DKA. Almost 10% of the US population has diabetes, which is a staggering amount. 90% of the population is type 2 diabetes, and it disproportionately affects people of color. 1 out of 3 DKA cases are type 2 diabetes. So remember that just because someone has type 2 diabetes does not mean they can't present in DKA. Type 2 diabetes actually has a stronger genetic predisposition than type 1 diabetes. What's our pertinent history when we're considering DKA in the differential? Do they have a history of diabetes? What's their medication compliance? Do they have a history of substance use? And are they having polyuria? On physical exam, are they tachycardic? Do they have hyperpnea, which means that Kussmaul breathing, which is one of those things that once you see it, you'll never forget it, and you'll always be able to identify it. Now, this table here goes over the diagnostic criteria for DKA. I don't want you to memorize this table. What I want you to think about is what are their serum or urine ketones, and what is their pH? So things that we are always going to order on those we are thinking about DKA. Finger stick. We always want a beta hydroxybutyrate and a venous blood gas at the very least. And in the venous blood gas, what we're looking at is the bicarb, and we're looking at their pH. A pH of less than 7 is very, very, very concerning. There's also a new modified criteria that just looks at serum and urine ketones and pH. Which actually simplifies diagnosing DKA quite a bit. How are we going to treat DKA? Fluids, 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 fluids. So those in DKA are typically 6 to 9 liters of fluid down. Those with HHS are usually about 12 liters down. So first and foremost, they need IV fluids. And then also treat the underlying cause. Is this new onset diabetes? Is this an issue with their medication compliance? Is this a diet issue? Do they have an underlying infection? We always want to treat the underlying cause. Very important, you are never going to give insulin until you have the BMP back. Insulin shifts potassium into the cells. So in a patient with DKA who has a sugar of over 600, sure, we can give them insulin and get that sugar down, but we don't know what we're doing to the potassium. And that can predispose patients to dysrhythmias, even cardiac arrest. So first and foremost, we're going to hang fluid. Now, sometimes it gets complicated with patients who have other comorbidities and you're not sure how much fluid you can give them, how much they'll tolerate. But for the most part, fluids, 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 fluids. Treat the underlying cause. Insulin once you have a BMP back. And bicarb if and only if their pH is less than 7. These patients can tire out and tire out quickly. So you do everything you can to avoid intubating them because their acid-base balance is so disturbed. When you intubate them, it can cause a whole host of additional derangements. So we do everything we can to avoid intubating these patients. It is very important to note that in kids, we limit our fluids initially to 10 cc's per kg bolus at a time because we want to reduce the risk of cerebral edema. And last but not least, something I wanted to go over is the decompensated patient. A 27-year-old trans woman presents complaining of shortness of breath for 3 days. She has a history of asthma with multiple admissions and 2 previous intubations. She arrives to Kipnick with poor air movement and hypoxia to 82%. What are the next steps in emergent management? So what I want you to take away from this is that this is a patient who is decompensated and is going to need an advanced airway. Now we're going to pull out all the stops and try and get this patient turned around, but we need to be ready to intubate. So what are our indications for advanced airways? The patient can't maintain a patent airway. They can't protect their own airway because they're altered. They are not having good gas exchange. So patients with large PEs, patients with large pneumonias, patients with COPD, where their gas exchange is impaired. They can't tolerate their own secretions. So rarely epiglottitis, I think angioedema, or patients with severe hemodynamic instability. So your floridly septic patient with a blood pressure of 60/40s needs every bit of metabolic demand going to perfusing their tissues. By taking over their work of breathing, we can help redistribute their metabolic demand. So these are things that I want you to keep in mind. When you see a patient and you see that they're being intubated, ask yourself why. Ask yourself the indications and go over this, because it'll help you become more comfortable with when to intubate and when not to intubate, and identifying sick versus not sick. So in summary, shortness of breath is by far the best chief complaint. Always remember your ABCs. Always, always, always get an EKG. And remember to consider pathology beyond cardiac and pulmonary systems for shortness of breath. I hope you guys do wonderful on your audition rotations. Feel free to reach out to me anytime. My email is alyssa.eily@gmail.com. And thank you all for coming to this talk. And here are my references.